So I think we move on to the case-based panel discussion. Dr. Sanyal did talk about pregnancy, but there are other issues associated with a common disease like NAFLD, like erectile dysfunction, a common gallstone disease, celiac disease. And to discuss all that, we have Dr. Sunil Taneja, who will be running this panel discussion. And may I also invite the panelists, Dr. Maharishi, Dr. Varun Gupta, Dr. Gaurav Pandey, this side please. Dr. Govind Makharia and Dr. Manas Panigrahi.
My sincere thanks to Professor Gaur Chaudhary and the team for inviting me here and giving me this opportunity. So we've heard about this multi-system disease and the multi-directional connect in this. So in next 15-20 minutes, the format of this presentation would be a case-based panel discussion, and we have this esteemed panel with us. So what I will do is, we have been given 5 clinical conditions which I have to talk about. So it's going to be a kind of quick fire round. I'm not going to go into the details of the literature which is available with us, but then try to discuss some of the issues which are related to these conditions. Okay, so before I start, I'm going to start with this audience question. Which of the following conditions is not associated with MASLD? Gallstones, polycystic ovary syndrome, erectile dysfunction, irritable bowel syndrome, and none of the above. So I think we'll give 10 seconds for this, and we'll go forward and then discuss. So I'm going to show this question in the end also, and let's see the answers to this question. Okay, so we've seen this slide so many times that fatty liver is there, and if you have these cardiometabolic risk factors, then you call them as MASLD. Now, these are the cardiometabolic risk factors which actually cause this multi-directional connect and leads to so many other conditions which we'll be discussing today. We've heard about the global prevalence also, it's very high. We've heard about that the prevalence is very high in India also, but then whenever you are investigating for a disease, obviously you will be picking up NAFLD. So if there is, whether there is a cause or an effect relationship or it's just an association, we'll try to see in this presentation. Okay, so first part is going to be about gallstone disease and MASLD. Now, we know that the prevalence of gallstones in India is very high, especially North India, and in that Gangetic belt, the prevalence is much higher as compared to the South. Now, let's begin with this simple case. A 52-year diabetic, hypertensive female patient who presented with complaints of recurrent pain abdomen for 6 months, and on examination she was obese, AST/ALT was mildly elevated, albumin was normal, ultrasound showed grade 3 fatty liver with gallstones, and the LSM was 7.1 with a cap of 334. Now let me ask Dr. Sudhir, what is the relation of gallstones with MASLD?
So gallstone and MASLD have bidirectional relationship. Actually both the disease have same risk factors in form of age, ethnicity, and metabolic risk factor, like insulin resistance is the key factor for MASLD, and similarly insulin resistant precipitate supersaturation of cholesterol which can precipitate gallstones. So they are interrelated. Patient with gallstone disease can have increased risk of MASLD. Similarly, patient with MASLD have increased risk of gallstone disease.
So we know that there is a bidirectional relationship between the two diseases. Now, gallstones will have high MASLD and MASLD will also have gallstones. Now, pathogenesis, I'm not going into the details. Let's see what should be the approach to patient with MASLD and gallstones. Any specific investigations which you would like to do in such a patient, Dr. Sudhir?
So this patient is having gallstone with MASLD. So we would like to proceed for MASLD investigation like fibroscan, AST/ALT already elevated, but this patient is symptomatic for gallstone disease. So he may or she may require cholecystectomy in view of symptomatic gallstone.
So how many would you agree that we should do fibroscan in all our patients who have gallstones? Is it required? But then there would be a group where patients who are undergoing cholecystectomy and the surgical procedure is abandoned because there is evidence of cirrhosis, or there would be patients who have decompensation after cholecystectomy. So any thoughts on that, Dr. Sudhir, that fibroscan should be mandatory in all patients, or it's in a specific group only that we should do a fibroscan?
So this patient had raised AST ALT. So for that purpose, we need further evaluation of MASLD. If patient is having symptomatic gallstone, then only cholecystectomy is indicated. If it is not symptomatic, then cholecystectomy is not indicated.
I think the message here is clear that routinely you don't need to do fibroscan in all your patients. So let's go forward. And any risk of gallbladder cancer in such patients when you have MASLD along with gallstones?
So because of MASLD, there is risk of primary liver cancer, but regarding gallbladder cancer, I am not aware of any data at present.
So I think there is data to suggest that gallbladder cancer as well as cholangiocyas might be increased in patients who have MASLD. But then if we try to correlate all these together, that is this an indication to a prophylactic cholecystectomy in asymptomatic patients with MASLD? Dr. Sweet, should we do cholecystectomy in patients who have MASLD because there is an increased risk of gallbladder cancer, there is an increased risk of cholangiocysia in these patients?
So prophylactic cholecystectomy is not indicated in patients with MASLD to prevent gallbladder cancer because there is huge burden of gallstone in our part of country. It is indicated as early cholecystectomy because there is risk of gangrenous cholecystitis in patient with diabetes, and we can consider early cholecystectomy. Prophylactic cholecystectomy is not indicated.
So would all of you agree that even if you have risk factors like diabetes, obesity and gallstones, you will not do a prophylactic cholecystectomy? I think in India there's a trend to do cholecystectomy in all patients with gallstones. So can we have a show of hands? Asymptomatic patients, cholecystectomy? No, the answer is no, but then the surgeons would not agree to that. Most of them would do cholecystectomy if you find gallstones. Anyways, let's go forward from this, and this is the second audience question. Which of the following statements is true? Gallstone increases all-cause mortality in patients with MASLD. Gallstones do not increase all-cause mortality in MASLD patients, and cholecystectomy reduces the risk of MASLD. And fourth is gallstones does not increase cardiovascular mortality in MASLD patients. So can we... Okay, so second choice. So I think let's go to Dr. Sudhir. Do you think that gallstones have impact on mortality in MASLD?
So in MASLD, gallstone itself does not have any impact on all-cause mortality in patient with the MASLD. Although it is most of the patient with MASLD, the mortality is because of cardiovascular risk factor or underlying fibrosis or cirrhosis stage.
So I think this message should be clear that even if you have gallstones, the mortality will not increase. So prophylactic cholecystectomy should not be done. And any risk of worsening of MASLD after cholecystectomy in Dr. Sudhir?
So there is risk of worsening MASLD after cholecystectomy. There are many studies which showed that after cholecystectomy there is increased risk of insulin resistance, increased risk of lipid accumulation, fat accumulation in the liver, which increase MASLD. And MASLD after cholecystectomy in patient with MASLD, there is increased risk of primary liver cancer, cirrhosis, as well as other complications of cirrhosis also.
So I think again there's a pathological basis for this, that after cholecystectomy MASLD might worsen also. So no indication for doing a prophylactic cholecystectomy in patients with MASLD if they are asymptomatic. So let's go forward and let's go to the second topic which has been given to us, PCOS, infertility and MASLD. And we've heard Dr. Sanel about this, that there is hyperandrogenism, there is anovulation and polycystic ovaries on ultrasound, and these patients can have NAFLD. Simple case to begin with. This is a 26-year-old female, obese, and she was being evaluated for infertility, and during evaluation she was found to have PCOS with fatty liver. So let me go to Dr. Varun. So how prevalent is MASLD in PCOS, and what is the reason for this?
So when we talk about MASLD in the population of PCOS, so it is significantly higher than the normal general population. The odds ratio in one of the study from BMJ is as if we have a multivariable analysis, it's up to 4.2. And there are other data, if you can just scroll the slides, that there's one large group which says that almost 42.8% of the PCOS patient had MASLD, in this group from BMC, and the data from the ASLD review says up to 52% of the patient of the PCOS will have MASLD. And in the general population, it's only 1/3 of the population. So the number of patients of MASLD in PCOS young reproductive age group is significantly higher. Another data where they have compared MASLD in PCOS versus without PCOS, the relative risk is significantly higher in PCOS population than in non-PCOS population.
So I think message is very clear here that the prevalence is much higher as compared to the general population, and to the tune of 70% it has been reported. So reasons are, which Dr. Varun will tell us, I think.
So the reason, the MASLD, obvious reasons of insulin-resistant obesity and diabetes mellitus are all there. But the point to be highlighted here is hyperandrogenism, which is a clear feature in PCOS and which add on the incidence of MASLD in the PCOS population. So there is high androgen circulation in the body, in addition to conventional MASLD pathogenesis of insulin resistance, obesity, inflammation, and some genetic factors.
I think the metabolic milieu is altered, which we've heard in the afternoon also. So, but then I will not go into the details of this, but then definitely there is a predisposition of patients of PCOS developing MASLD now. So, are there any endocrine aspects of MASLD beyond insulin resistance, and does MASLD predispose to infertility? This was the other question which we have to answer.
So in MASLD, the endocrinology aspect of MASLD, when we talk to, we will like to highlight 2 points here. And the male population. So in the MASLD people, it's found that the testosterone levels are low. Deficiency is prominently in male MASLD. And when we talk about females, when they go to the menopausal state, there is low estrogen, which increases the incidence of MASLD in this population. So these are 2 points which I would like to highlight briefly about the endocrinology.
So hormonal balance is there, which leads to development of these complications, and this is what happens in females. There's an effect on ovarian function, hormonal dysregulation, and endometrial and implantation issues, which leads to infertility in females. And in males, it is because of the testosterone levels and the effect on sperm quality and function and erectile dysfunction and libido. So let me go to Dr. Gaurav Pandey. Is erectile dysfunction more prevalent in MASLD and it can lead to infertility? And why does it happen?
Yeah, erectile dysfunction is more common in MASLD. It's almost up to 1/3 of patients with MASLD would have erectile dysfunction. And basically, if you look at the hemodynamic metabolic profile, more the metabolic parameters are fulfilled for the patients fulfilling metabolic dysfunction, metabolic syndrome criteria, higher the risk for erectile dysfunction. If you look at the people fulfilling metabolic syndrome criteria, more than 50% of them would have ED. So, and the prevalence increases with severity. Severity of liver disease, severity of BMI, severity of hypertriglyceridemia, severity of waist circumference as it increases. So the whole metabolic milieu shifts towards the severity of the prevalence and the severity of ED. Coming to the second question.
So causes, why does it happen?
So basically causes, if you have high glucose, hyperglycemia is there. Hyperglycemia will lead to glycation of proteins and lipids increased. Advanced glycation end products would be there. This advanced glycation end products would act on receptors for this. That's called RAGE. And this will lead to endothelial dysfunction, oxidative stress, cell death. Because of this, endothelial dysfunction would progress. If you look at the obesity itself, when excess fat infiltrates the visceral fat, you have increased inflammation, cytokines, which destroys the fine balance between the hormones and the protein binding hormones. Their protein binding hormones also decrease from the liver. So sex hormone binding globulins decrease because of production of the liver and because of the fat milieu that is there. This will lead to increased free testosterone. The negative feedback cycle would inhibit the hypothalamus pituitary androgen cycle, will further lead to reduction of testosterone levels. Plus, suppose a patient has accompanying hypothyroid. Hypothyroid again is pretty common in this scenario. So you have decreased T3, T4, that will directly impact testosterone levels. Then you have decreased LH, FSH, again that will indirectly impact testosterone levels. Now with that, you have increased TRH levels. Now increased TRH levels will cause hyperprolactinemia. Hyperprolactinemia will again inhibit the pulsating release of GnRH. So multiple scenarios with these comorbidities, almost each of them independently would affect the metabolic milieu and lead to ED.
So I think it's again the multi-directional connect in this, and we've heard about obesity, we've heard about BMI, waist circumference, we've heard about diabetes. IR per se is a predictor of erectile dysfunction, and this has been seen in studies. Hyperlipidemia, especially hypertriglyceridemia and low HDL levels are associated with erectile dysfunction. Another condition which is peculiar is obstructive sleep apnea, which can also lead to development of erectile dysfunction, and you might get patients who have erectile dysfunction and they are suffering from OSA. Gaurav talked about hypothyroidism. It can lead to MASLD as well as erectile dysfunction due to various mechanisms. And in clinical practice, Gaurav, do you assess for erectile dysfunction in patients with MASLD, and how would you like to treat if a patient with erectile dysfunction MASLD comes to you?
So honestly, in a busy OPD, it's a miss almost. We never go to the details. Probably if you have specialized OPD where you can give more attention. So honestly, in our day-to-day gastro OPD, we don't really go in depth. You should, because it is linked with severity of each of these metabolic parameters. So higher or the severity, the more the discomfort and the more likelihood that the patient would have ED. How do we treat? So treatment, you have, most of the common drugs that we use have tadalafil and are very effective. But the important thing is we have done lot of studies have been done on the metabolic profile. So if you lose weight, ED improves. Drugs like SGLT2, GLP-1, there are multiple papers that if you use SGLT2, GLP-1, apart from weight loss, they have significantly better effect on ED. So weight loss may not be up to that extent, but ED significantly improves. So endothelial dysfunction also improves. That further helps improvement in
I think the bottom line is control the risk factors, control obesity, hypothyroidism and other conditions, and if you're able to bring down the weight, it might help. So I think let's go to the third topic here, celiac disease and MASLD, and we have Professor Govind with us. He's a stalwart in looking at patients of celiac disease and as well as research also, and he's going to present some interesting data. Sir, would you like to present some data on celiac disease? Yes, sir. Can we have his slides, please? Dr. Govind's slides.
Thank you, Sunil. Wonderful topics. All we know that literature perspective of celiac disease globally. Globally, about 40 to 60 million people have celiac disease. And in India, about 8 million people have celiac disease. Most are undiagnosed. So there's a concept, everybody thinks celiac disease, it means malnutrition. I mean, this would be underweight, but it's not true. Majority of patients with celiac disease have normal weight. Only few of them are underweight, and even 18% are either overweight or obese at the time of diagnosis. The first thing, the concept that every celiac is underweight is not true. Second, that as they put on gluten-free diet for the treatment of celiac disease, almost 9% will have change their BMI category, go to a higher BMI category, and they have an increase in BMI on gluten-free diet. I'll come back why it is so. The question comes that how many celiac patients have fatty liver or metabolic syndrome at diagnosis? And this review we did, with Nisant did this review, and what we observed that of all celiac, 100 celiac, 15 have fatty liver at diagnosis. And if treated for gluten-free diet, 14 are added further. So 1 year of gluten-free diet, almost 29, or say 1/3 develop fatty liver disease. So this is very relevant thinking about 80 million people of celiac in the world. How many will be fatty liver? Second, coming to metabolic syndrome. Again, 4% of patients have celiac disease, have metabolic syndrome at diagnosis, and with gluten-free diet, almost 20 are added. Become 1/4 have a metabolic syndrome. So this is very relevant in context of celiac disease. Furthermore, this led to increase in cardiovascular mortality and also liver diseases. About 5% of all cryptocirrhosis have celiac disease. Why it happens? In celiac disease, because of villous atrophy, the intestines are hungry, and as intestines start improving with a gluten-free diet, it becomes hyperabsorptive. At the same time, there is hyperphagia. More importantly, the gluten-free diet which is available, it has more fat compared to a non-gluten-free food. So this is a high-fat diet, and also it has a lot of ultra-processed food. And therefore, these patients keep taking gluten-free food and put them to risk of hypermetabolic states. So what do? 3 things. We must know that also all celiac screen for fatty liver disease is very relevant. If you screen for celiac fatty liver disease, we need to understand how many have it. I told you to start with 15, and after gluten-free diet, 14 more will have a fatty liver disease. Then monitor over time, because more patients will be added, and more importantly, educate them. As we educate for gluten-free food, we must educate them for more physical activity and also more balanced diet. And lastly, we need to have awareness among stakeholders, because gluten-free food, to increase taste and its palatability, it has more fat. So all the food industry should have knowledge of this and should try to decrease fat in their gluten-free food products. Second, that all the regulators, government, and all agencies should also consider this as important part in life of celiac disease. Therefore, there should be legislation that all food industry control fat in the gluten-free food. With that, again, I'd like to reiterate that celiac disease is not uncommon, and it also has a multiple metabolic complications. Thank you for your attention.
Can I have my slides back? So I think the message here is that celiac disease patients also can have MASLD, and I think it's the gluten-free diet which actually plays a role. And these patients should be monitored, and so the outcome of patients with celiac disease and MASLD, we don't have long-term data on this. So last but not the least, and we're going to talk about irritable bowel syndrome and MASLD. Can I have the slides, please? It's not coming here. Okay, so last topic for today's discussion is irritable bowel syndrome and MASLD. And is this just a coincidence, or there's something more to it? Now, a 30-year male obese patient, case of diarrhea predominant irritable bowel syndrome, not improvement with treatment by a physician, comes to a hepatologist with diagnosis of fatty liver. This is a common scenario which happens. So they would come to you that I have a problem with my liver, and that's why I'm having these complaints. So Dr. Manas, is there a relationship between MASLD severity and IBS symptoms?
So if you'll see, MASLD, there are a lot of literature. In MASLD group, around 30% will have IBS. And in IBS population, if you'll see the prevalence of MASLD, around 70% will have this MASLD. In our series, we have seen around a lot of the patient, we have given the terminology incidentally detected NFLD. So they are not NFLD. They have come after IBS, dyspepsia and all those. We have seen in them fatty liver. And in that group, out of 632 patients, we have seen around 30% have IBS. And if you will see the severity of MASLD in IBS population, that will bidirectionally affect. MASLD population, we obviously give them exercise and diet. If somebody has IBS, they are suffering from anxiety, depression and all those things. So that again difficult to treat those MASLD patients with this IBS population. So we have to treat both the disease simultaneously to address this issue.
So could weight loss ameliorate IBS symptoms by influencing intestinal bacteria?
Yes, definitely. Again, there are a lot of literature. There is a prospective study published from UK which shows that when there is exercise and there is weight loss, the severity of IBS decreases. So again, I will say weight loss will decrease the severity of IBS in this population.
So is there a cause and effect relationship between the two, or it's just an association of IBS with MASLD?
So we will see IBS and MASLD both are a chronic inflammatory state. And pathogenesis wise, if you will see, there is leaky gut will be there, dysbiosis is there, and milieu, this metabolic milieu and cytokines milieu, both in this condition are, there is dysfunction. So both are related. Again, this toll-like receptor in MASLD cases, they again infuse cytokines, and that can cause this irritable bowel syndrome.
So I think again this multidisciplinary connect and gut dysbiosis, which plays a role in IBS as well as MASLD, and both the things can be correlated. This is the hypothesis which has been suggested, and presence of IBS symptoms may pose a potential barrier to the optimal management of NAFLD patients, because they would not take the treatment for MASLD as well as IBS together, and there's always a problem treating patients of IBS. So unifying principles of management is again lifestyle modification in these patients, try and take care of SIBO, and there is a concept of bile acid diarrhea which can happen in patients with IBS. Some role of FSR agonists, but then there's not much data on this, and obviously you have to control the risk factors. So take home messages from my presentation. MASLD is not an isolated liver condition, but part of a broader metabolic dysfunction that involves multiple organ systems. Frequently coexists with several comorbidities, including celiac disease, erectile dysfunction, gallstones, IBS, and PCOS, due to shared metabolic and inflammatory pathways. Aim should be prevention and control at an early stage. It's a multi-dimensional treatment protocol which should be followed. Lifestyle modification is the key to management. Diet, exercise, and metabolic control can help reduce the severity of all these comorbidities. Personalized treatment plans addressing underlying metabolic dysfunction and inflammation are essential for long-term health. Future research is needed to explore novel therapeutic approaches that target both MASLD and its associated conditions, which Dr. Sanya also talked about. And it's not just about hepatology or a hepatologist. You need to have a multidisciplinary team to manage these patients. And once again, I would invite you all to Chandigarh for the annual meeting. The registration and abstract submission are open now. Thank you very much. We'll be happy to take questions. We still have 2 minutes left.
Dr. Sunil, sir, this side. Sir, IBS, celiac, and MASLD, and especially if you go for a lean NASH type of a thing, most of the things, they're overlapping, and the treatment strategy and the diet planning almost is the same in every manner. Most of them are getting treated, by something or the other. Any comment on that?
Sir, I think, again, so lot of disconnect between all these conditions. So difficult to treat, and lifestyle modification still remains the treatment of this. Yeah. Sir, please.
I had promised I wouldn't be speaking, but I thought I'll share a case with you that happened recently. There's a young man, he was about 30 BMI, came to me with erectile dysfunction. And he was obese, he had fatty liver disease. So as having been inspired by the MASLD conclaves, I thought it's fatty liver disease. So I put him on therapy, told him to do exercise, lose weight, even gave him an antidepressant. He came back 2 months later and he said there was no improvement. And I was struggling what else to do. Sildenafil was one option, but then I was wondering what else to do. I shared this case in Lucknow. And interestingly, I was at a loss. This fellow comes and says, sir, I was sleeping in a hotel room with a friend, and he told me that my breath was stopping when I was sleeping, and he has taken a video. And I realized that he had OSA. And you know, the funny part of OSA is that you can't diagnose it by history. Because unless the wife or somebody else is there, he often doesn't report it. So all my advice that get up in the morning, do your exercise, fell flat because you're tired in the morning. Whole day you're tired, and he had erectile dysfunction. This I thought was a very good learning from my point of view, that the fatty liver could be a consequence rather than the cause. Your comments, Gaurav?
Who came with IBS symptoms. I saw a lady who came with IBS symptoms, and sir had shared this anecdotal case with me. And that person had a lot of IBS symptoms, but during discussion he just fell asleep. This case that sir presented just now stuck with me. Patient was obese, had fatty liver, had a lot of IBS symptoms. And then when I discussed with the patient that do you occasionally get up in the night feeling a bit discomforting? She said, yeah, I have palpitations, I feel I am oxygen hungry. So it's not only a correlation, probably weight has multiple other parameters. That patient may come with to different speciality. It's a unifying thing. And if you have different IBS symptoms, would be there in patient who would have sleep apnea. Multiple reasons are there. Fatigue would be there. Insomnia would be there. But if you tie the knot, maybe with lifestyle modification and medicines, most of these symptoms will be taken care of. Really thankful for Gaur sir to have presented this case, and suddenly this case getting struck when I saw him.
Can I make a point?
Ask a question? Yes, sir, please.
Yeah, very nice session, Sunil. Just maybe two questions to Govind. I think very nice data.
Only one, sir. Only one. Only one allowed, sir.
Only one question allowed? Okay. So I'll put two questions into one then. One was, you said that the celiac would have fatty liver close to, even after GFD, close to 30%, but which is same as the general population. So is it more in celiac fatty liver? And your data, your own data, which you have not shown, as you have also shown some of the cryptogenic liver disease, especially cryptogenic cirrhosis, could be related to celiac. But then I'm not saying that. But then if you screen some of our MASLD, many of them would have positive TTGA or EMA. So the second question is that is that positivity of TTGA is again telling you that they really have celiac, or it could just be an epiphenomena there?
I'm not sure at this point of time that it is epiphenomena, but one thing is very clear. Celiac disease, you take gluten-free food, which is high in fat, one, and your intestine absorbing more. So you're likely to have more metabolic diseases and fatty liver disease. So this looks very straightforward. But the second question you asked about, if all fatty liver disease, if you screen for celiac disease, how many will have celiac disease? Is that the question? I don't think we have any data on that. That's a good study to look at all fatty liver disease and screen for celiac disease, look at how many have celiac.
Can I ask a question? From here, from the floor? This side, sir. Yeah. So we're looking for a template for gluten-free and healthy diet. Is there any data on blue zone diet? Because it seems like it's associated with the highest longevity.
I didn't understand the question. It's not clear.
Blue zone diet, is there any research evidence that it would help MASLD?
So I'm not aware of that, sir.
Should I repeat it?
I'm not getting the question, sir.
Let me come there.
Blue zone diet, he said. Blue zone diet.
Which one? Blue zone. What is that? I don't know about blue zone diet. What is the blue zone diet?
I think we'll have the discussion later on.
Dr.
During tea
Sanyal,
time.
Dr. Sanyal can... Yeah.
So there are these areas where there are areas where people have high longevity, like in Okinawa, and there are places in the Mediterranean. So where these people live very long, their diets are considered blue zone. The big issue with all of these areas is that, is it the diet alone, or is it a way of life where people have less stress, they spend more time with their families. It's a combination. They're more physically active, amount of alcohol they consume, and everything else. So it's really unclear whether it's that simple an answer, that if you just eat this, you can behave badly all day long, just drink some Mediterranean, olive oil in the evening and you'll be fine. So that is clearly not true.
Yeah, certain areas in Japan are there where the life is different.
Right. Thank you, Sunil, for
Thank you, sir.
finishing in time.
I
Can
thank
you
all
please-
my panelists. Thank you very much.